By the end of this video, you're going to never forget the 3 acute coronary syndromes using these memory hacks. But before we lock in anything, first you need to understand it. This is what we're going to cover, and we're going to throw in loads of high-yield facts, mnemonics, and buzzwords so that you can nail your 3 acute coronary syndrome diagnoses. It is super high yield for your medical exams. If you're new here, my name is Matt. I consistently rank first at medical school, and now I help students and healthcare professionals study medicine smarter and remember more for longer. If you want to slash your revision sessions in half, then you may want to check out some free pages of my Never Forget study series. Link for that is in the description. Let's get stuck in. The myocardium is fed oxygen and nutrients from the coronary arteries. Think of them like water pipes. The smooth flow helps to keep them enriched with blood, so it keeps doing its thing of keeping you alive. But over time, these pipes can build with plaque. It happens when LDL cholesterol starts accumulating in the intima layer. Our immune system doesn't like that, so monocytes start gobbling up, forming foam cells. As more and more accumulates, local inflammation sets in. Local inflammation leads to more and more cholesterol deposition, which first forms a fatty streak, but gets bigger and bigger until it starts clogging up the lumen. That's not good. This is what we call an atheroma. It doesn't stop there though, because smooth muscle cells can migrate into the atheroma and fibroblasts can start depositing collagen. A stable plaque has a thick fibrous cap, whereas an unstable plaque has a thin fibrous cap, which makes it more prone to rupture. If it does rupture, then blood is exposed to collagen. That stuff is super sticky and a blood clot starts to form, which, as you may have guessed, blocks the flow even more. Let's take a step back. Depending on how clogged those pipes are, we land on a spectrum of the coronary heart diseases. For stable angina, think of that pipe just being narrowed. Usually it causes no issues unless if your heart's working extra hard. Unstable angina is also a narrow pipe, but it randomly occludes at rest. Luckily, the blockage is short-lived. It causes pain, but it's pretty temporary, so it doesn't cause any cell death. STEMI is when we get a persisting partial blockage. It's enough to kill the cells, specifically in the subendothelial layer. Whereas a STEMI is a total blockage. Again, it starves the myocardium of oxygen and you get a full thickness infarction. These last 3 conditions are the acute coronary syndromes. In theory, you could give everyone an angiogram and see how patent their coronary arteries are. But of course, you're never going to do that for everyone presenting with chest pain in the emergency department. Instead, you're going to require 3 components: a convincing history, ECG changes, and troponins. We're going to dig into every single one of those so you truly understand it and you never forget it. But first, let's be active in our revision. Trust me, you'll remember far more for far longer if we keep testing you as we go. So pause the video right now, and in the comments, I want you to try to recall the 3 different acute coronary syndromes. Let's say a patient comes in with chest pain and you're trying to figure out if this is acute coronary syndrome. Before we put a label on it, we need to be thinking, well, is this actually cardiac sounding chest pain? Rather than any of the other causes of chest pain, such as GI problems or respiratory problems, but we'll go into that in a minute. Cardiac chest pain is known as angina, which is derived from a Greek word for strangling. This part's super high yield. You need to know these 3 features to nail your definitions. Firstly is central crushing chest pain. Patients describe it like someone sat on their chest. It tends to last more than 20 minutes and it can radiate to the left arm and to the left jaw. Second, is it worse on exertion? Thinking back to those pipes, if they're slightly blocked and the heart's working harder, then the blood flow is going to be worse. And thirdly, is it relieved by GTN, which helps to vasodilate those coronary arteries, or is it relieved by rest? We can use the Feynman technique to simply recall those 3 features. In essence, we're saying there's the classic heart-sounding features, which get worse when the heart's under more strain and get better when the heart's under less strain. Now, if you get all 3 of those features, we call that typical angina. Whereas if you have 2 of them, we call it atypical angina. If you only had 1 of those features, we tend to call it non-cardiac chest pain. For example, your patient could complain of a tight squeezing pain in the center of the chest, and it does respond to GTN, but it doesn't get worse on exercise. After some further questioning, you might think, well, this doesn't tick the first or second criteria, but it is relieved with GTN. That would be a non-cardiac chest pain, and is actually the classic vignette for an esophageal motility disorder such as diffuse esophageal spasm. If it isn't ticking boxes, you might want to start thinking of other differentials. However, it's not always as simple as that. This is where silent MIs come in. In specific demographics, such as being elderly, female, diabetic, there are patients who may not actually present with the typical sounding chest pain despite having a raging MI. The classic example is type 2 diabetics who have an autonomic neuropathy. The visceral afferent nerve fibers aren't so good at actually getting that pain signal from the heart to the brain, so they don't actually feel it. So be aware that silent MI is a thing and you shouldn't just disregard it because they don't tick these boxes. Also, patients don't just present with chest pain, they may have palpitations, loss of consciousness, or the diaphoretic symptoms such as nausea and vomiting and a cold, clammy sweat. Okay, let's test your active recall again. I want you to pause the video and this time try to record those 3 features of typical angina. Before we move on, let's talk about differentials. What else could it be if it's a non-cardiac chest pain? I've actually made a whole video on this, but in summary, what we should be doing is thinking of a system. When it comes to chest pain, think of the organs in the chest, mainly the heart, the lungs, the GI tract, all the musculoskeletal systems surrounding that, and then the nerve fibers going off to the brain to interpret that pain. You can take a few differentials to each of those categories to help your recall. For example, heart causes could be pericarditis, lungs could be a PE, the GI could be gastroesophageal reflux disease, MSK being rib fractures, and the brain being psychosomatic chest pain. Definitely check out that other video if you haven't already. Okay, so we've decided whether it's typical, atypical, or non-cardiac chest pain. The next step is looking at the ECG. We'll start with the big one, STEMI. Remember that a STEMI is that total blockage and it causes a full thickness infarction of the myocardium. If you recall an ECG, you'll probably remember that the ST area is all about repolarization. But if infarction is set in, such as an NSTEMI or a STEMI, the myocardium has difficulty repolarizing. We define STEMI as ST elevation in 2 or more adjacent leads. If we're talking limb leads, then it's greater than 1 millimeter above the baseline. Whereas if we're talking chest leads, then it's 2 millimeters above the baseline. We can roughly tell what area of the heart's affected by the leads which we're seeing. V1 to V4 is the anterior part of the heart, with V1 and V2 particularly being the septal area. V5, V6, 1 and AVL is your typical lateral view of the heart. And lastly, 2, 3 and AVF is the inferior aspect of the heart. Those leads are looking from the bottom upwards. Don't forget that ST depression in V1 to V3 can indicate a posterior MI. If you were to add on more chest leads past V6, going around the back, then you may see ST elevation in those posterior leads. That's a posterior STEMI. Although we may see ST elevation in the leads facing the injury, we may see what we call reciprocal changes in those other leads. For example, in the anterior MI, you may see ST elevation in V1 to V4 with reciprocal depression in leads 2, 3 and AVF. Don't forget though that anatomic variation does exist, so this is just a rule of thumb. There's also one other criteria for STEMI, and that's a new left bundle branch block. They can be tricky to pick up, and the buzzword here is checking Scarbose's criteria, but I'll make another video about that one. If you see a raging STEMI, then the diagnosis is clear. But if you don't see one, you may just be catching it too early. Remember, ECGs evolve over time, which is why it's super important to get serial ECGs in any of your patients with chest pain if you're concerned. There are 4 stages of an evolving STEMI on ECG. You can never forget it, but imagine someone doing a backflip on the ECG. It starts out with hyperacute T waves. Then the ST elevation kicks in. Then the Q waves start developing, followed by inversion of the T wave. Those ST changes tend to go back to normal, but Q waves and T wave inversion may persist. Let's move on to NSTEMI and unstable angina. They may have normal ECGs, but you're going to need to look out for the signs of ischemia. Recall that NSTEMI results in infarction of that subendothelial layer, whereas unstable angina does not. Again, the classic ischemic changes involve the ST area, either ST depression or T wave inversion. That damaged muscle has difficulty in repolarization. In case you want to understand it further, here's exactly why it happens. Repolarization is when myocytes become more negative on the inside. They're locked and ready for another depolarization event. They do that by leaking out potassium. Now, the myocardium actually repolarizes from the subendothelium to the epicardium. We're talking about a negative current here, so on the ECG lead, it's going to be picked up as a positive T wave. But in ischemia, remember, it's that subendothelial layer which gets affected first. It stops the myocardium from repolarizing properly. The ECG pattern flips, so we see that T wave inversion. Okay, you're doing great so far. Let's stop to test your active recall. In the comments, I want you to recall the stages of the maturation of ST elevation on an ECG. Now we move on to the famous troponins. They're found in cardiac and skeletal muscle and help with muscular contraction. But more importantly, they're a validated marker for picking up cardiac ischemia. Troponins are made up of 3 subunits: troponin C, troponin I, and troponin T, but it's those last 2 which release into the blood when the cardiac myocytes are injured. Therefore, it rises in NSTEMI and STEMI, but it does not rise in unstable angina. Generally speaking, that troponin is going to rise within the first few hours after. It will then reach its peak over about a day, before slowly dropping over the course of a week or so. But there's a catch which will be well known to anyone who's worked with troponins, and that's that troponins can be raised in lots of other conditions too. Here's a list of some causes here, but it may help you to categorize it into 2 key causes: those which put more strain on the heart, like tachyarrhythmias, or those that interfere with the metabolism and excretion of troponin, such as chronic kidney disease. Finally, let's put this all together. How do we use these three features to diagnose ACS? Let's bring together those three components: the history, the ECG, and the troponins. It will help you pinpoint on whether you have unstable angina, NSTEMI, or STEMI. For all of them, you should be expecting cardiac sounding chest pain, but like we said earlier, don't forget about the demographics where silent MIs can happen. Second is the ECG. STEMI should be a spot diagnosis, but don't forget that a left bundle branch block can obscure the interpretation of that. That's where Scarbosa's criteria comes in. For NSTEMI and unstable angina, there could be ischemic changes such as T-wave inversion and ST depression, or the ECG could be normal. Don't forget to check serial ECGs. Lastly is the troponin. Troponin is present when there's infarcted tissues, so we don't typically see it in unstable angina, but we do see it in NSTEMI and STEMI. Again, you want to do serial troponins to see if it's going up, going down, or staying the same. Now, if all of that makes sense, we're going to do our final active recall stop. Pause the video, and in the comments below, I want you to tell me the features which would differentiate unstable angina from NSTEMI. You're nearly at the finish line. Let's recall those high-yield things to know about acute coronary syndrome. Firstly is those blocked pipes, to remember the difference between stable angina, unstable angina, NSTEMI, and STEMI. Next were those features of cardiac sounding chest pain. Is it atypical, typical, or non-cardiac chest pain? Next is the evolving STEMI features, just by remembering someone doing a backflip on the ECG. And lastly, we put it all together to identify the specific acute coronary syndrome. That's combining the ECG findings with the troponin and the history. That's a wrap. That was a big one, but I promise you it's super high yield for your medical exams. If you found this useful, please like, follow, and share it with your mates. You can check out those free pages of the Never Forget study series in the links in the description, and I'll see you on the next one.